see okay? Good. Can everyone hear okay?
Yes.
Marvelous. I'll get going then. Brilliant. So I'm going to talk about core outcomes after surgery, which is a project that I've been involved with for several years. And hopefully the concept of core outcomes will become clear over the course of this. But the whole sort of background to this is the idea of kind of reframing the way we measure outcomes after major surgery. And the reasons for that I will go into a little bit to begin with. So everybody's interested in outcomes. Why does everyone want to know about outcomes? Well, for lots of what I hope are fairly obvious reasons. Outcomes and the results of what we do are of immediate interest to everybody in the healthcare space. So patients are obviously interested in having a good outcome from the treatment they undergo. Clinicians are interested in knowing that they're doing a good job. We're interested in knowing whether we're doing better or worse than other people in other places. And all of that's only possible if we're measuring what we're doing. And also relating the outcomes that we get to the structures of the healthcare structures that we're using and the processes that we're implementing, and how those relate to the outcomes at the end of it all. Now, the first chap to sort of really encapsulate this idea was Lord Kelvin in the late 19th century, who was very into the Victorians were dead keen on measuring everything as much as possible, and quite rightly so, because as he pointed out, if you can't measure it, you can't improve it. If you don't have good data about what you're doing, then you are, stabbing around in the dark every time you try to change anything. So that's the sort of basic background to it all. But which outcomes to collect and how to collect them is a tricky subject, because collecting outcomes, collecting any sort of data, obviously requires a bit of manpower and it requires some resources. And the way we've done it traditionally is increasingly being sort of reframed by lots of interests. But one prominent one, which I've just put their logo up here, is some people called the Patient Centers Outcome Research Institute in America. So they're funded by the National Institute for Health in America, and they're very interested in sort of promoting patient-centered research and patient-centered care. And the idea that the sort of two things they really push are the idea that care should be reflective of a patient's needs and autonomy and what they want out of it, and focused on outcomes that the people on the sort of receiving end really notice about and care about. And we, this will not be news to any of you. The way we've kind of traditionally looked at outcomes in healthcare is to measure some fairly broad brush clinical outcomes, and also sort of resource use outcomes. So how long are people in hospital for? Do they need extra resources that we weren't planning on giving them, like blood transfusions or kidney filtration or going back to the theatre or readmission to hospital, that sort of stuff? And how much does it all cost? So obviously we're spending a lot of money in healthcare, and getting better outcomes for less money is sort of in everybody's interests. But these sort of traditional outcomes are don't tell the full picture, and there is a big has been lots of recognition in the last sort of 10 to 20 years that actually there are lots of much more multidimensional, richer, and more complicated outcomes that reflect the sort of overall results of a patient having surgery. And most of these are measured from the patient perspective. So you may have a successful hip operation nominally in terms of not dying after the operation and not getting post-operative complications, but whether the patient is pain-free and can walk and do all the things they were hoping to do after the operation 6 months down the track is harder to measure, and is not something that we always pay due attention to. And as you can see in this sort of wheel thing on the right, there's lots of different aspects to recovery from surgery, and we are slowly sort of starting to come to terms with that. Here are just a few examples of recent articles that have all addressed this thorny problem, if you like, that traditional clinical perioperative outcome measures are not really telling us the full story, and that we should be measuring patient-reported outcomes as well, and how best to do that. So my interest in this area is all about a thing called core outcome measures in perioperative and anaesthetic care. And core outcomes are a sort of a broad brush approach to try and get researchers to, and indeed kind of anyone measuring stuff in a clinical space, to measure stuff in a standardized way, and in a way that can be compared from one centre to the next or one trial to the next. This thing at the bottom, the COMET initiative, sorry, it comes out a bit pale on the screen, stands for Core Outcome Measures in Effectiveness Trials, and they are a group of researchers based in Liverpool and Bristol who sort of have been promoting this for the last 10 years or so. The idea that in complex healthcare settings, and a lot of this relates to kind of chronic conditions, there are many different ways of measuring outcomes that different researchers choose in a slightly haphazard way, and comparing results between trials is very, very difficult if you don't do stuff in a formal, standardized way. So they are very keen on developing and promoting the use of core outcome sets, which means an agreed standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in a particular healthcare area. And my work has been looking at trying to develop one of these for anaesthesia and perioperative medicine. Now, the kind of process for coming up with a core outcome set is not set in stone, but there are some sort of basic principles which involve lots of relevant stakeholders, do some sort of background research on what's going on in the area of interest to begin with, and then run some sort of consensus process to develop your core outcome set such that you can get something that everybody agrees on. And that's broadly speaking what we did. So Compact was a sort of three-stage process. We did a big systematic review to begin with to try and describe the way outcomes are currently measured in perioperative research trials. We then did a big sort of survey across perioperative clinicians and patients who've had surgery and people who've looked after patients who've had surgery, about what outcomes they think are important to people having a big operation. And then we ran a Delphi process, which is it's a sort of form of consensus building that grew out of, it actually came out of the Cold War. It was all the basically all the defense chiefs of the Western world sitting around trying to decide what was the best way to counter the military threat from Russia during the Cold War. And the sort of idea that getting lots of experts together to choose a kind of common pathway was a better way of doing it than everyone setting out on their own paths. So anyway, so we ran a sort of Delphi process which runs along similar lines to decide the sort of final core outcome set for all this. That's just a flow diagram which doesn't come out terribly well on this screen, showing the kind of different stages. And here's what we found. So we did a big systematic review of randomized controlled trials over the last 10 years. And we kind of kept this, we deliberately kept this to the kind of top 4 journals by impact factor within the fields of medicine and anaesthesia, and only big trials that had recruited at least 100 patients. And the reason for that was because we didn't really want to know how outcomes were reported in tiny little journals of dubious quality that nobody reads, and so on. We wanted to know how are outcomes reported in the big, well-funded trials with decent methodology that are influential and read across the world and actually practice changing. And what we found was, unsurprisingly, quite a lot of variation and inconsistency and heterogeneity in terms of the way outcomes are reported. So even for something like mortality, which is a commonly reported perioperative outcome, as we know, and that was borne out by our systematic review, timeframes were pretty variable. the way that mortality was defined, whether it was all cause or due to certain causes, was again quite variable. The sort of degree of detail in terms of describing even something as basic as mortality was pretty variable between trials. And when it came to much more complicated outcome measures like patient-reported outcomes or post-operative morbidity outcomes, the variability was all the greater. Anyway, so that kind of that told us what we'd hoped we'd find, which was that there is a lot of heterogeneity and inconsistency in the way outcomes are reported across the perioperative world. And that's why we need a core outcome set in order to try and improve the standardization of the way that's done, because that makes it easier to compare results between different trials and to make sense of them all in systematic reviews and so on. And then we did a big survey across lots of hospitals in England and Wales, asking patients and carers and clinicians what they felt were important outcomes after major surgery. And this was a fairly simple sort of cross-sectional survey study where we just got some basic demographic data and asked respondents to rate 7 different sort of outcome domains in terms of importance on a scale from 1 to 10. And again, sort of fairly unsurprisingly, the vast majority of all respondents rated things like the operation being successful, not dying after the operation, and avoiding permanent post-operative complications. All of those were rated as critically important by the vast majority of respondents, which obviously stands to reason. The sort of slightly more patient-centered metrics, like being comfortable after an operation, getting out of hospital, returning to normal activities, were rated lower overall, but importantly, they were rated significantly lower by clinicians than they were by patients and carers. So there was really no difference between patients and carers in the traditional perioperative outcome measures described at the top, but the ones that are overtly patient-centered were less highly rated by the clinicians than by patients and carers. And then we conducted a Delphi process in which we got a bunch of patients and carers and clinicians, all of whom had participated in the sort of second stage, the consultation bit. And they took part in this Delphi process, which involved two rounds of online surveys and then a face-to-face workshop with lots of group discussions and debate, most of it friendly, about which outcomes are most important and which ones should make their way into the core outcome set. And the sort of driving goal for all this is not just to decide, which outcomes are important in certain circumstances, but which outcomes are so fundamentally important that they should be measured as a kind of baseline in any perioperative trial that you care to mention, and unless there's a very compelling reason not to. In other words, outcomes that really are going to be relevant to any patient in any surgical trial and any clinician who's managing their care. So we had 67 participants in this Delphi process. We started off with a sort of long list of candidate outcomes of 66 outcomes that are under consideration. We did a sort of round of online rating through an online survey and whittled that down to 57 outcomes. We then did another, and during the second survey, you get to see what the answers were during the first survey. So you see if your score was massively different from the sort of general mean, or whether it was broadly speaking in line with all the other participants. And the idea of the Delphi process is that if you were kind of in line with the general consensus, you go, great, my opinion is pretty much sort of on track. And if it was a massive outlier, you think, oh, do I really think that's massively important or massively unimportant? And adjust your score, either to say, actually, no, I do think this is really important, and then the rest of the group gets to discuss that as well, or you say, oh, actually, what was I thinking? That's not as important as I thought it was, and you sort of revert to the mean. So it's all kind of regression to mean is the principle behind it all. And then at the final workshop, we had 13 clinicians and 13 patients and carers of various different backgrounds and sort of experiences, and lots of group discussions followed by sort of coming together plenary discussions, all facilitated by some independent moderators. And at that workshop, the core outcome set was eventually agreed. And this is what it looks like. So none of these are, I think, particularly out there in terms of, things you wouldn't expect. But that's the entire purpose of a core outcome set, is to try and, agree on some basic, let's all measure these as a baseline, and then measure other stuff on top of it according to what's of interest in the particular trial that I'm running. So unsurprisingly, mortality and perioperative complications were both high up there. But the emphasis in perioperative complications was on ones that have a sort of lasting impact on patients. So there was lots of discussion about, should we measure all postoperative complications and adverse events, and a general feeling, not really. The asymptomatic troponin rises, the minor pneumonia that gets better after a couple of days or whatever should not be a core outcome, whereas anything that causes lasting harm or disability or has a major impact on a patient's life or the rest of their life clearly warrants being measured as a core outcome. Total number of days in hospital, unplanned readmission, again, those are things that we kind of measure already, but they were, again, felt to be kind of directly impactful for patients, as well as being, having implications in terms of costs and healthcare resource use. So those found their way in. And then the sort of recovery after surgery very much ended up being split into the kind of short term and then the longer term. And the short term stuff was, can I get back to where I was, preoperatively, and do I need extra carers? Am I an extra burden to my family, and so on? And then the longer term health related quality of life was the sort of big standout as a what's my life like 6 months, 12 months down the track, following the surgery? Have I got to sort of where I hoped I would be in the long run? And then there were some other outcomes that were sort of didn't quite make the cut for the core outcome set, but were strongly supported by a large majority of all the participants at the workshop, and were therefore sort of put in a subcategory of additional important patient-centered outcomes, which were sort of strongly recommended for inclusion in trials unless there's a good reason not to, but not sort of absolutely mandated. And pain, nausea and vomiting, and then sort of mental and psychological well-being after the operation were all within the sort of short-term domain. And then in the sort of longer term, it was patient satisfaction with operation and or willingness to choose the same again, which is a thing that I'm particularly interested in measuring, but is quite a difficult concept to measure in a robust way. But that's a discussion for another day. Anyway, so that sort of talks you through it all in a very quick whistle stop. And what's the sort of overall conclusion from this? Well, this is the first core outcome set that we're aware of that sort of spans the breadth of perioperative care, and the whole purpose of the process was to be as collaborative and involving of relevant stakeholders as possible to make sure that we end up with outcomes that are genuinely meaningful for, well, not just patients, but for clinicians looking after them as well. And the sort of recommendation from all of this is going to be that this core outcome set should be a default starting point for choosing outcomes for clinical trials in the future. That's not to say that you can't also measure lots of other outcomes if you think they're relevant to your particular trial, but even if it's just one line saying we recruited 200 patients, there were no post-operative deaths, that's an outcome that should be reported as a standard of sort of trial reporting. And this kind of wider, where does all this fit into the perioperative medicine arena, I guess? I mean, as I discussed at the beginning, I think the overall sort of driver for this is that mortality and postoperative morbidity are important, but they're not sufficient to describe the full range of, well, you know, how has everything gone in terms of having major surgery. There are lots of patients who may not suffer mortality or postoperative morbidity, but whose results from the operation are not quite as good as they would have hoped. But that's not captured in the outcomes that we currently measure. And the way to capture those sort of more subtle patient-centered nuances are through using multidimensional, more long-term patient-centered outcomes in order to get sort of patients' perspective on the sort of overall outcomes from their surgery. Now, doing that is difficult and it's resource intensive, but there are good and pragmatic patient-centered outcome measures already in existence, and it's really just a case of using those a bit more and using them in a sort of robust and standardized way. And in the longer term, it's certainly something I'm quite a big believer in, the idea that we have preoperative risk discussions at the moment, but they are, you know, they are not very detailed or informed by anything more than you know, you've got a CPET, maybe you've got a P-POSSUM score, you've got, you know, contrast that with every time you fill out an insurance quote for your car insurance. They want to know about a whole load of different things, at the end of which you get given a figure which is quite finely tuned to your likely risk of having a crash or making an insurance claim or whatever. My feeling is that we should be trying to enrich our preoperative conversations with patients so that they have a more realistic and sort of fuller appraisal about what the kind of full range of possible outcomes after the surgery are. And at the moment, we can really only frame that in terms of your chances of surviving, your chances of being in hospital for a long time, your chances of having a life-changing postoperative complication. But it's very difficult to put numbers on your chances of being able to do X, Y, or Z. And I think that's where shared decision-making conversations really need to go. So I will run through some very brief acknowledgements. Massive thanks to Ramani, who's supervised me through all this, and to various other researchers and lay committee members from the Royal College of Anaesthetists who were on the Compact steering group. Big shout out to Sarah, who organised the Compact workshop pretty much single-handedly and has been incredibly helpful through all stages of the Compact process. And lots of the research team at the Royal College of Anaesthetists similarly have been extremely helpful and supportive in getting a lot of this off the ground. There are probably some people in the audience who might have even filled in a P-Commerce survey or recruited patients for P-Commerce, so likewise gratitude to all you guys. But on that note, I will finish and invite any thoughts or comments or questions.